So I'm here with Jessica.
Yes.
Jessica, I'm not sure of your exact job title. I'd say it's
Classic!
probably laboratory technician.
Pretty close, yeah. The same thing, yeah. Medical laboratory technician.
Alright, so Jessica's a medical laboratory technician, which means you work in a laboratory.
Correct.
A laboratory mainly designed to process samples
Yes.
of different fluids from human bodies.
Yes.
And then you guys also do pathological services there, right?
And microbiology,
Okay.
culturing.
All right, so what are some of those services? Like what tests do you do?
We could do a urine culture. We could do a culture on a wound.
Mm-hmm.
We do the flu swabs. We do a flu culture where it actually grows. It's like a confirmatory test because sometimes if doctors get a negative for a flu, they still want us to culture it just to be sure. So then we actually grow it on plates.
Oh, okay.
So back to general lab, coag, hematology, urinalysis, blood bank, chemistry, special.
So let's put that in lay terms for people that are watching right now.
Okay.
When we culture something, we're trying to grow it, right?
To grow, to isolate the organism that potentially could be causing an infection. So it's grown on media that and at the appropriate temperature for the microorganism that we are looking for. So that's your staphylococcus, your streptococcus, the gram-negatives.
Those
like
are bacteria.
E. coli.
Those are
Yeah.
bacteria you're talking
Yeah,
about.
yeah. So staph and strep are gram-positive, and then your gram-negatives are like E. coli and some others.
Okay.
Can't think right now.
Okay, so one big misconception that I think a lot of my patients run into in their lines of questioning for providers is, what are the culture results? I'm usually asked that immediately, probably within a day of sending the sample. But there's a reason you're shaking your head when I describe that, and why is that?
Because cultures take anywhere from 2 to 5 days, depending on the organism. So some of your respiratory stuff can take 5 days to grow. So we update the report every day that nothing has been isolated yet, but until that 5th day, we can't finalize it as negative.
Sure.
And yeah, so blood cultures are allowed to incubate, grow for 5 days to potentially find something.
And then we also do cultures on urine, where we're looking for bacteria in urine, right?
Mm-hmm. And urines actually are quicker. You could probably get an idea of the direction you're going within 12 hours. It grows pretty fast. But that doesn't mean that the lab tech schedule coincides with constantly checking the cultures, because we check the cultures, that we have set increments of when we check them and when we're allowed to update them, regardless of what we see or if we have time to check them.
Okay. And then the secondary part of that culturing that we test for is sensitivity too, right?
Correct.
And as far as I understand it, sensitivity gives us an idea of which antibiotics the bacteria is susceptible to.
Correct. So even though we told you we might have updated the isolate and we say that it's E. coli, we still have to do the sensitivity, which we actually set those probably at the end of the shift, and they won't be done until the next morning, because that's how long it takes for them to run, depending on what instrumentation we're using. And then that'll tell you which antibiotic that it's either susceptible to or resistant to. And resistant is the important part, because it typically a patient presents and you have an infection, you start antibiotics, but the doctor doesn't necessarily know that that's the correct antibiotic that's going to kill the organism. And that's a great treatment plan, because chances are it could be the correct one and we're nipping that in the bud right away. But if the results come back and we've had you on whatever antibiotic and it's not the correct one, then your doctor, your nurse is going to read that lab report and say, hey, this one's not the correct one, and then we can then get the patient on the correct antibiotic.
Yeah.
which is important for admitted patients because they probably have other things going on. But then the patients that go home, they are discharged from the ER and they don't know that they're not on the correct antibiotic until, I'm sure we have a way to call them and let them know.
Yeah, we do.
Yeah.
So we do call patients and we give them lab results very commonly after they come back if they're discharged immediately. So other things we do in the lab, or I shouldn't say we, but other things you do in the lab involve blood banking, right? All right, so give me like a quick rundown of what a blood bank is and does.
A blood bank types and screens a patient's blood for what blood type you are, and if you have a screen means that I'm screening for antibodies, and if you have any antibodies, you either acquire them from previous blood transfusions, or another important question when I ask nurses about females, I'll ask them how many children they've had. So I'll be talking to an ICU nurse and this woman is 50 years old or 60 years old and they're wondering, why am I asking you how many children they've had? Well, every time a woman is pregnant, they're potentially exposed to the father's antibodies, and if that actually gets introduced into their blood system, they can develop an antibody against that antigen on the father's red cells.
Okay.
So women can acquire antibodies that way, and that's another reason why, I don't know if you know this, but like women that have had 5 or 6 children, they typically aren't a good candidate to be a donor for like United Blood Services.
I didn't know that.
Because of the potentiality of the antibodies.
That's really interesting, actually.
Yes.
Okay, so when we talk about antibodies, we have these cells in our body. So imagine a little red blood cell. And these antibodies are expressed on the exterior of the cell, right?
Antigens are on red cells.
Oh, antigens are on red cells.
And antibodies are in your plasma.
Okay.
But I have this conversation with myself every day at work, so it's okay. So antigens are on red cells and they're genetic and they're on the exterior of the red blood cells. And then in the plasma are your antibodies. You can get that in an immunization, right? So you're developing your immunity and you're developing these antibodies that flow around freely in your plasma, waiting until it encounters the thing that they are like programmed to fight against. So your immunization for the flu, it's triggered for certain strains of the flu virus. So you have these little things floating around in your plasma, waiting until it encounters that. So if it encounters whatever strain of flu and it's the right antibody, it'll attack it and kill it.
Yeah, so these things activate the immune system and stimulate an immune response when they come into contact with what they're programmed to come into contact with. And so the importance of matching the antigens on the exterior of those cells to the antigens of the blood we're going to give is
very important.
And
or what?
Why is that so important?
Because if we transfuse a patient and they have antibodies against anti-K or KEL, we call it KEL, and the donor red blood cells that we're giving them have KEL on it, the body is going to attack those, and now instead of like therapeutically like helping the patient, we're actually now giving them another immune response thing to fight while they're trying to get treated for whatever's going on with them.
Yes, exactly. So this is a massively dangerous situation because of how large of an immune response happens immediately. And so when I give blood, I usually have to do, I have to do vital signs every 15 minutes. I'm specifically monitoring temperature to see if there's a spike in that temperature indicating an immune response. If the pulse rate jumps, that's something else that I'm usually concerned about. And as nurses, we're trained that if we even just suspect a transfusion reaction, the first thing we do is shut off the transfusion. That's pounded into our brain constantly in our training and in our nursing school and then in our practice later on. Because getting the wrong blood product could potentially kill a person very quickly. And then we have other secondary measures for administration too that include 2 nurse verification processes. So I, along with another nurse, are required to do checks, and we actually do 3 checks. Do you know about all these?
Yeah, because quarterly I have to come and shadow nurses.
Oh, that's awesome.
And watch them and question them, like, do you know what taco is? Do you know what trelly is? Do you know the signs and symptoms?
Fantastic. Awesome. Okay, so stop me if I'm wrong or incorrect in any of the things I'm saying, please, because she is an expert in these matters, for sure. So, yeah, me and another nurse will compare the blood band. We put a band on your wrist after we type and screen you. So we take a sample, we match it to the band, we send that sample to the lab. As long as we don't screw up in how we label it, that sample is now matched to you and you're banded with it. We receive the blood sample from the lab, and then we match the blood sample to documentation. We match both of those things to the blood band in the patient, and then we verify all of that with what we have in a computer as well. So,
and all those verifications you're doing, we do as well. So when I get the specimen, I am very thorough, and I'm checking the spelling of the last name, the spelling of the first name, the date of birth, the medical record number. I do it initially, and I was also taught every time I am entering a blood type or a screen, I do it again. Because do you know how many times the name has changed in the computer just from me starting the process of doing the type and screen to then entering the results in the computer? And then I have to call the nurse and I said, I'm sorry, you gave me this specimen, but it's no longer good because registration or whoever changed the name of the patient in the computer, so now we don't have patient ID.
Yeah, that would be especially complex with like jaundice situations, I suppose. That'd be really vexing and irritating. So we'll have patients come into the emergency room, and for some reason, if we cannot identify them and they need blood products immediately, we have to give them a name, which is usually John Doe or Jane Doe. But they still have other identifiers we use, like medical record numbers and account numbers for verification processes, even if we don't have, a valid date of birth for them. So they still get those verification measures, but like she's saying, if registration is not contacted by family subsequently, maybe a few hours later, and we learn their name, actual date of birth, and we update the system, that blood band we just put on them with John Doe, invalid, for very good reasons. Because we
don't have patient ID confirmation of that point.
we need to be accurate in everything we do with these really dangerous products that we're administering.